What I wanted to visit with you on today was giving this very positive and wonderful story that Tim and Walker have just pointed out, and how bright our future looks, some things that we might want to do to address it. And so, taking a page out of Stephen Covey's book, I'm going to start with the end, show you what our conclusion is, then work through all the factors in the landscape that brought us to that particular conclusion and end with it. And so what I'm going to do is combine the work of the Physicians Foundation with some work that we're doing at the Texas Medical Association and our county societies. And I could see that Mike Derizet and Greg Bernica and Ahuva Turk are helping us do that. So let me get started. Looking here, we take a look at the market spectrum. Where are our doctors? Are they single? Are they in hospitals? And what type of a practice do they have? The question that one has to ask, and our databases really are set up to address these issues, is where does the doctor practice? How is the physician being paid? And how are our services geared towards providing that? One of the reasons why they're running to hospitals or looking at other issues is we provide great advocacy, we provide our traditional services, we have our vendor relationships, but we're not in the integration market or the transparency market or all the other words that the hospitals and our insurance company colleagues use. I must say that it's kind of interesting United is sponsoring this session, because I believe, personally, that medical societies and the insurance companies are aligned right now. Now, that could probably change going into the future. 10 years ago, we sued the insurance companies to form the Physician Foundation. That's all changed. Our market is upside down. I work with the insurers, and they're the ones that want to sponsor our programs and support them. Maybe we'll get the hospital's attention. Market change is going to take many forms. There are different models here. You've probably seen slides like this in the past. Basically, it says what will individual physicians do going forward, moving from the traditional solo fee-for-service practice all the way to a fully integrated practice. Fully integrated means working vertically with the hospital, having bundled payments, being able to do population management, having your revenue cycle management under control, not the old-fashioned George Conomike's pin board where you take care of things. Very different kind of a model. Large groups are doing this. In Texas, 72% of the doctors, and that's maybe even 80%, somewhere between there, are still small and solo. Even in California, talking to my colleague there, Dustin Corcoran, he tells me, while I would think California has fully integrated model, he says about 50% of the state is like that. 50% still small and solo practices. So that we still have an opportunity not only to help to run to the technology world, helping the large groups, but we also have a role in helping what still remains to many of us, the small and solo physicians. So we concluded, and I'll tell you how we got to this conclusion, that a medical society can provide a role, could show value to their membership and non-members by doing a couple of things, three things. One, leadership. We need to show the doctors leadership and how to lead. Two is how do you help independent physicians to aggregate while remaining independent? How do you provide them with those services so they can afford them? How do you provide them with the technology? So one, leadership. Two, I have here, I have aggregation up there. And three is the technology services. For example, United has a subsidiary called Optum. They have a lot of services. Many of you would be surprised to know that Xerox provides much of the backroom work that the Blues use in doing their claims processing and revenue cycle work. So we came to the conclusion that what we need to develop, and we're calling it, it's really an MSO, but Steve Levine, my communication director, says nobody's going to know what a MSO is, so we call it a physician services organization, a PSO. Because at least in the media, physician services. The media thinks, well, if there's any media people here, I apologize. They think they know what that means. So how did we get there? Well, we talked about what services we'd offer. Of course, the traditional management services, electronic processing, credentialing, EMRs. We talked about aggregation. IPA is a term that's been around for a long time. It doesn't have to be an IPA. Any type of a grouping would work. Working towards a physician-direct developed ACO. And as Tim points out, hopefully the doctors will stay in charge once we take advantage of that particular model. ACO, just integrated practice using all the services. Jeff Goldsmith, who wrote a paper for the Physician Foundation, says that the government has it backwards, that the bundled payment that the ACO gets shouldn't be given to the hospital. It should be given to the physicians and the physician group. Let them distribute the dollars, because it's the doctors who are going to have the savings from admissions and readmissions and unnecessary ER visits, which is where the savings come out of. That's the big savings that we're looking at, which, if you think about it, is contrary to the interests of the hospital. They have beds. 80% of a empty bed, it costs 80% of a full bed to have an empty bed. So the hospitals, on the one hand, are trying to demonstrate that they could be efficient. On the other hand, they have the cross purpose of keeping their beds full. Only the physicians could control that. So as both my colleagues have pointed out, our physicians have tremendous power. We just have to show them how to use that. So how do we get to this point of view? Well, I started out by looking at something the Physician Foundation puts out every year called a watch list. And we identified the 5 major problems facing medicine. Uncertainty over the Affordable Care Act. Does bigger mean better? As you can hear from Tim, we don't necessarily think so. 12 months to 30 million new insureds. The erosion of physician autonomy, which is number 1 on every doctor's list. And of course, red tape and regulatory issues. We also commissioned a paper on the top 10 irritants facing medicine. We've gotten some media play on that as well. So starting with that, what is a physician's response to uncertainty? We've heard the survey results. These are additional focus group results as well. Most doctors want to stay in the practice they're in right now, but 21%, almost a quarter of them, are selling or considering selling to a hospital. Pretty significant. It's hard to talk to a new resident or a physician in training that's talking about hanging out a shingle, right? They're all going into practice. I think I've met one, a psychiatric resident who's going into private practice. And this is Texas. You wouldn't expect that there. The number 1 issue that doctors point out when we have surveyed them is they'd like to join a large group with other physicians, but there's a limit to how many can join. And the hospitals are grabbing market share up, as Tim points out, because of the side-of-surface differential. Look what happened to cardiology. Another way to look at it, not looking to sell, the large majority, but 21% considering selling, that's significant for our business. Very difficult to demonstrate value, at least maybe some of you have the magic bullet, to doctors that are employed. Advocacy has always been our number 1 selling point, community services, our vendor relations. It's kind of a different market. Do we talk to the individual doctors? Do we talk to the administrators? Do we get ourselves into a management labor situation at some point down the road? Lots of considerations as our market evolves. Numbers of employed doctors, we see it dropped a little bit in the downturn in the economy. The biggest number tended to be working with other bigger numbers, working in other physicians' offices. Lately, however, it looks like doctors that are looking for employment are in employed situations, mostly going to hospitals because they're the ones that are offering the 3-year contracts. Is bigger better? Tim pointed this out. Let's see, is this Care First? This is my first example. I have 3 examples, which is why I couldn't share this sort of proprietary information I was able to obtain from different plans. Care First Blue Cross, it's a Blue Cross Blue Shield plan. They wanted to study why they had differentials in physicians that were independent in their plan and those doctors that were employed in the system. And so the first thing they looked at, this is example one, first thing they looked at was what's the difference between an independent physician and those that were in the health system. And we could see that the per member per month is higher in the system, the number of admissions is higher, cost per admission higher, all the way down the line. So they asked the question, why is that? My assistant got fancy there with that one. So they came up with this is what Care First, a very large, successful health plan, came up with. Could we introduce global caps? Again, remember we had the global capitation in the past. The doctors weren't ready for it. Again, those medical groups that are integrated want to have the global cap so they could do the full risk management for their patients. Could they have better outcomes, and could they preserve physician independence? I'm using Care First because it's a physician-friendly health plan. So they came up with something that I thought was quite interesting. They call it their Rosetta Stone. Now, what does it say? It says that the sickest patients with advanced diseases, smallest percent of the population, largest percent of the cost, right? Now that shouldn't surprise anyone, but they kind of categorized it this way, and they said, how are we going to address these different populations? Of great interest, of course, is the second band down, because that's where they could have the most impact. Multi-symptom, aged population, very difficult. It's going to be costly, and I'll take a look at Medicare in a minute. So they looked at this, and they turned it upside down. They said, another way to look at it, critical illness, 3% of their members, 29% of their cost. 8% have multiple chronic illnesses. They could address that group. 78% of the admissions were for those groups. So where do they want to put their resources? Where do they want to use population management? Well, on that group that are using most of the resources. They took a look at their Medicare population and found that 18% of the advanced critical illness group also used more than half of their services. So that's why they had that differential that we talked about earlier. So this is something that a physician's office really can't do, a large group can, but surprisingly the insurance companies working with an individual health system, in this case Care First, which had a combined doctor-hospital approach to it, was able to address this. And what are they going to do? Set up care management. Maybe they'll put a care coordinator in the medical group office to take care of that particular patient group. Share the savings that you get from one reduced admission would be huge for that practice. That's the direction that they're needing to go. Small practices can't do that. Perhaps we can help them do that without having to join a big system. So we're starting to think along those lines. So we saw Care First, bell goes off. Maybe that's something we can do for our doctors. Federal health spending, put it into perspective, the biggest chunk of our spending is health care, and it's been growing at an increasing rate. I think it's about 10% last time I looked at this every year for every 20-year period. So, and it's going to continue to grow, as Tim points out, with the Affordable Care Act. The other thing, other point, the baby boomers have always been driving our healthcare system. Well, as they move into the Medicare population, the millennials are going to become the biggest percentage. So if we do care management with this younger group with preventive services, perhaps we can reduce the costs that our Medicare population is looking at right now. That's another idea in the Affordable Care Act. It's one that the hospitals and the insurers are looking at right now. It's one our individual physicians need to have direction and help on. Medical spending, of course. All of us hear about primary care, right? Everything is primary care. But look at the percentage of the health dollar that goes to primary care. It's only about 6%. And yet that seems to be the only discussion. So perhaps there's something there. The medical home has been touted, and there really hasn't been any data on does it work or not. Well, it's a question I had in my mind because it's an issue that comes up in talking with the insurers and anyone else as you're trying to develop help for your primary care doctors. This came out of Commonwealth Fund, typically not one of our favorite institutes, but when they have data we like, we use it. Right, Tim? Yes. Thank you, Linda. So here's the patient-centered medical team. It's a team concept. You're all familiar with it. I won't spend a lot of time. But Commonwealth actually published this on their website about 2 or 3 weeks ago. They showed that in a patient-centered medical home, fewer admissions, fewer readmissions, and lower costs. First serious data from a serious institution demonstrates it works. Something that our doctors could use in negotiating with the insurance plans. Another model. Here's example number 2. Advocate. Why did I pill Advocate Healthcare? I think they're an Illinois-based health plan. They got the #1 quality ranking in the country recently published. So we might want to take a look at what they had to say, right, if we're developing a service for our doctors. So they're talking about clinical integration. I showed you the map in the beginning, moving from a primary care ambulatory business to a integrated business with measurements, population measurements, taking care of the whole population versus an individual. They said this is the way we're going to do it. This is more high level than the Care First model. Caring for the sick, caring for the well. We've talked about this quite a bit. Now, what was their conclusion? Again, remember, #1 quality ranking in the country for a health system. Culture. We've heard that. They are changing the entire culture of the institution. So it's not just the metrics, it's the culture of the institution. So we saw the metrics from the Care First model. The Advocate model says we've got to change the culture too. How do we work together? How do we do our business? So we're thinking about this as we're developing our model for how do we help our doctors. Getting back to the cost drivers, is bigger better? We necessarily don't think so. But again, being opportunistic, happened to look at the AARP magazine. I don't get it, of course, but I found it on somebody's desk. I think I got it in your office, Tim.
You have to be 50.
Yeah. Yeah, I think I found it on your desk. And it happened to be the issue that demonstrated that even AARP doesn't like bigger systems as well. They said that it's higher prices, what's happening, and they're asking a lot of questions. My view, of course, is consolidation is another word for monopolies. Monopolies don't lower costs, they increase costs. So it's interesting to see that the AARP has come to the same conclusion that our surveys and our Physician Foundation has come to. A paper that Tim and I wrote just a while ago for Forbes, an op-ed, said doctors are not the cost drivers, which the debate at the time was it's all on the physician's shoulders. He or she is the reason costs are going up. Our research demonstrates there's a lot of other factors, technology being one of the top ones, which is why we're talking to the insurers and the Optums of the world on how we could help doctors with this technology. So, bigger is better. Site of service differential, both Walker and Tim and I, the MedPAC has also come out with a report saying site of service is a huge cost driver. You're familiar with that? You provide the same service in the individual doctor's office. As soon as the doctor gets employed by the hospital, same office, same place, but they're getting the Part A reimbursement. The price goes up because you're getting the facility fee in addition to the professional service. So I just pulled out some examples to demonstrate that. Hopefully I don't have any of my hospital friends in there because they hate this slide. Cost per patient day, of course we're going to look at the hospital cost. If we compare it internationally, it's huge. And so the savings, of course, are admissions, readmissions, unnecessary ER use. That's what we're focused on. One estimate that this came out of Vanguard Health System, example 3, the hospitals are saying the answer to the problem, the cost problem, is bundled payment. You give us the bundled payment, we'll save you almost 6%. Our answer is give the hospital the bundled payment, and of course I'm biased, having represented doctors my whole career. The hospital is going to take their percent, right? When the government or the insurer says, hey, we've got to reduce costs, they're still going to take the same percentage scrape off the top. Who's going to get the reduction? It'll be our doctors. So the bundle going to the hospital is very dangerous, and we need to have a lot more control over that. And that's the leadership and the control we're talking about providing our doctors. We don't give them that bundled payment, the hospital's not going to take a loss. It's our doctors who will take the loss, in my view. One answer that some of the insurers are looking at is so-called narrow networks. I have a lot of words on it. Coming up with a diagram was a little challenging. Basically, a narrow network says, we will dub these doctors high quality, we will dub these doctors low cost based on some metric that none of which any of us have ever liked. We've seen lots of different ones, blue stars, red stars, everybody has one. I think we liked United's the best, even though we hated that one too, but of the ones we dislike, we like that one the best. And then low cost and high quality. And so one answer is, let's narrow our doctors down. Now, we might think of that, and we fought that in Texas. We had a bill on silent PPOs and other narrow network bills, and we fought them legislatively and have been luckily successful. However, if one thinks about that, if we're in control of these narrow networks, what's a potential role for our medical societies? Well, all the doctors are A students, right? They want to be A+ students. And so A students are either in one of those little pie slices, but that big group that aren't in the big pie, those are ripe for education. So if we, and again I'm talking a little blasphemy here, I think Susan talked about disruptive change. It's going to be pretty disruptive, so here goes. One thing one might consider is if we could work out arrangements, work out some sort of, I don't want to say joint venture, any of the words the lawyers get crazy over, but some sort of an arrangement with, yeah. Thank you, Steve. So if we could work on an arrangement with the insurers, for example, and we could provide the educational component, our medical societies, for all those doctors that aren't in those networks, wouldn't United like that if all of them were low cost, high quality? Absolutely. So maybe, as opposed to fighting this, and of course we're going to continue with our advocacy, but perhaps this is an opportunity. Turn to the medical societies to help these doctors become the low-cost, high-quality providers. They all want to. So, I mean, just turn it upside down. Look at opportunities as well. So we looked at that as well in coming to the conclusion. So I pulled this one out. It just serendipitously was United sponsoring us, and I used the Optum model. But there are many of them out there, Aetna, Optum, all the big insurers, Xerox, TriZetto. There's a number of technology companies that offer solutions because we're not going to build anything. We're going to use what's out there. We don't have the capital. I'm saying we, us medical society execs, we don't have the capital or the wherewithal, for the most part, to build these models, per se. We tried to in the past. It takes millions and millions of dollars. But we can work out arrangements where we can make this information that the hospitals, the back office, the insurance companies have used, where we could provide them to our doctors. And how do we get that front-end piece? How do we translate this high-level technology into our doctor's office? And I just put Optum up because they're a good example, probably one of the most well-known. So we had a design shop, a strategic plan, happened to be sponsored by Optum. My good friend Reed Tuckson was with United at the time. He helped us do that. He's since left, unfortunately. He's a great leader. He worked at the AMA. Many of you know Reed. And we spent they underwrote a 3-day program for Texas doctors. We brought some people in from Arizona, Tucson Medical Center is another great example of how a doctor group and a hospital can work together. And we said, MSOs and aggregation, that's something we could provide. We have the brand names, we have the networks of doctors, we have the trust and the credibility. Perhaps this is a role our medical societies can play. So that brings me back to where I started. Services, let's make the services available. Let's provide the doctors with leadership and The trickiest part, how do we take our independent doctors and help them to aggregate together so they could take advantage of this technology? Now, you might say, well, our employed doctors won't like that. Wrong. They will love that, because once they go into an employed setting, the average tenure is about 3 years, because that's what the contract is. And once they don't hit their productivity measures, which are impossible to meet, hospital sets them really high, they drop them. A lot of the doctors leave. So the continuity of physicians, a lot of traveling around. This will provide a little competition to the hospitals. It also provides, if we could organize our doctors, an opportunity for those doctors to have another option. They can go back into private practice with other physicians. So there's a benefit on both sides of it. At some point, we'll work with the hospitals, but right now, we have to show them a little muscle, you know, in my view. So what are the questions we need to ask, finally? Who are our members today? Who will they be in 10 years? And that goes into the different type of data that we have to collect. Can our society maintain its core values and adapt to this changing marketplace? And it's going to be a little disruptive as we change. We're going to have to work with people who historically we haven't. Work with people who we've sued in the past. Perhaps be adversarial with groups that we've been friends with. But if we're going to represent our doctors, that's the question. Those are the issues we have to consider. And finally, we all need a roadmap to guide our society through the changing landscape. I showed you the roadmap that we're looking at in Texas, developing with the state and the county, society, our leaders and medical groups, and with the help of the Physician Foundation, we're hopeful that we'll come up with a model. By the way, we're working with some other states as well. So whether it works or not, you'll hear about perhaps if they ever invite us back here, but we'll know pretty soon. Thanks a lot.